Good morning, everybody.
Good morning.
Good morning.
Hi. So can you tell us something about the case?
Yeah.
Sure.
Yeah. So, welcome to Apollo Cath Labs. Dr. Raj Dave, Dr. Shyam Kumar, Karunya, and a host of technical staff. Can we show the first slide? Yeah, this is a 51-year-old gentleman, smoker, presented with an extensive anterior wall ST elevation MI 3 days back. Goes to a local hospital where he was thrombolized with streptokinase with good resolution of symptoms and ST changes. Wall motion, 40 to 45 EF, hypokinesia, except for a small segment on the anterolateral wall where it is akinetic, with tissue Doppler showing probable non-viability in the small segment of lateral wall, but good enough for rest of the territories with good S prime. And then the RFT, the issue is that his creatinine was 1.9 at presentation in other hospital. Our EGFR was 45. So 2 days back, show that, next slide. We did the transradial coronary angiogram with probably 15 ml of dye, non-ionic under nephro care, protective regimes. And then you can see that is essentially a single vessel disease. Next slide. We took only 4 shots. Next. The next slide, please. The culprit lesion. Can you go for the next slide? Yeah, you can appreciate it well. Just before the septal diagonal axis. And then the next slide again. The cranial views show both the plaques. The main issues are before the septal diagonal and just after the septal diagonal, a bit long lesion. There is some small disease in the distal LAD as well. The diagonal is not a great sized vessel, and there's not much of microvascular blush as well in the diagonal territory. Going with the echo report, we know that probably is not a concern today. Next, the right coronary is only mild plaquing, proximally mild disease. And one day we waited for the 36 hours, repeated the creatinine. It is very stable at 1.5. So it is a ACS, recent thrombolysis, angina yesterday night, which relieved with sublingual nitrate, and then here we are. So Raj, what is your comment?
So, in summary, patient with acute coronary syndrome, this is pretty common in the Asian hemisphere, where a patient gets thrombolyzed, which is different than Western countries. But you can see that the thrombolysis does work. This patient had complete ST resolution. The left ventral descending artery is open. There is a long area of stenosis in a patient who has been a smoker and a newly detected diabetes. So what we have decided to do here is, given the patient's renal insufficiency, we are only going to do 3 runs, and the first diagnostic angiography that we have taken with the guide catheter is with OCT. So you can see that, so show the fluoro screen now, and that's the only angio we have done where I just put the wire in and we just did an OCT run, and that's where we are in the procedure. So what I like to show you is the OCT. It's a fairly straightforward case. So can we show the OCT now?
Next one.
OCT.
Yeah, the OCT run. Yeah.
Can we play the OCT run? So what you see on the OCT in this particular case is that there is a large amount of lipidic and fibrous plaque in this patient. There is also a calcified nodule. We did not see evidence of plaque rupture. However, we feel that it's possible that this patient is now 3-4 days post his infarct. He's gotten thrombolytic therapy. He's been on DAPT, including aspirin and ticagrelor, and high-dose statin therapy. So it is possible that if there was a small plaque rupture, that we don't see it today. However, we see several tight stenoses in this LAD with a MLA of less than 1.5 millimeters, as well as a large amount of fibrolipidic and fibrous plaque, as well as one calcified nodule that you see now at 1 o'clock on that image. Another tight lesion. We also do not see a presence of a lot of thrombus. you can see that starting from 2 o'clock to 9 o'clock, there is a large amount of fibrofatty plaque there, and then this is a relatively healthier segment proximally. So we did do some measurements here, and the proximal reference is about 3.68 to 3.7, depending on which frame we take, from EEL to EEL, and a distal reference is about 2.65. So, and the lesion length is about 28, 29 millimeters, depending on, where we end the proximal or the distal stent. So what I've recommended, is that we would use a 3/0 by 33 Zions, and then proximal portion of the stent we were going to go ahead and post dilate with a 3.5 millimeter balloon, given that the proximal reference is much larger. And then we will only do one more angiogram after that with OCT, and hopefully that should conclude this case. Any comments from the panel or moderators? We are open for any suggestions.
Dr. Nave, can you hear me?
Yes, I can hear you fine.
The calcific nodule in a 41-year-old, is it related to the renal dysfunction, or do you see it commonly?
No, so I showed this last night, that in acute coronary syndrome patients, only about 10 to 15% of patients, do present because of calcified nodule related ACS. So it's not a very common finding. However, in real life, we do see calcified plaque, which is different than an eccentric calcified nodule. So this patient does have an eccentric calcified nodule in one area. At least that's what we feel he has.
Could you show the audience that place which you're referring
Sure.
to as the calcified nodule, please?
Sure.
Go to the OCT, please. Yeah.
Yeah, do you see that now?
Yeah, we can.
Yeah. So that's the only area where we see calcium. The rest of it is all fibrofatty plaque.
And the fibrous plaque there is quite thin. It was measuring about
60 microns.
60
Yeah.
microns. It's surprising.
So on
that-
OCT,
yeah.
how would you distinguish an intermedial calcium or a calcific plaque from a calcific nodule as you were to define it?
I'm not sure that I understand the question correctly. Yeah.
I mean, rather
I
than
think
just
it's an
saying that this is a
experience, yeah.
calcific portion of the plaque, rather than characterizing it as a calcific nodule,
Yeah.
how would you, are there any cutoff criteria that you would be using?
Yeah, so I think that that's what Dr. Reddy was referring to, is the thickness of the cap in that area, and eccentricity, and how it's protruding into the lumen in just one segment of the vessel. And I think that this is sort of a pattern recognition stuff that you can get your eyes trained to, looking at it over and over again. If you have a calcified plaque, it's usually going to be, in a circumferential fashion, and the border is going to be much more sharply demarcated than a nodule of calcium. And those are the two, I think, the critical ways of looking at it. Do you have any other
Dr.
ideas?
Dr.
Arvind?
Rafael, is he around?
Nikhil, any comments? Whether this is, you would call this a calcific nodule or a intermedial calcific plaque or
I've just arrived, but yes, it looks like a nodule.
nodule? All right.
But
Arvind?
what is very interesting is that the cap, so as to say, is very thin,
Yeah.
Yeah.
and it's a mixture of calcium and lipid behind it.
Right.
Yeah. All right.
But actually, Anil, this is actually almost like an eccentric lumen, not like a concentric lumen with a one nodule seen. Then you can tell it is a
Projecting into the-
calcified
projecting
nodule. It's
into the
actually
lumen.
not as a concentric
I mean,
lumen.
it's
The
Pratap,
lumen
it's
is
not
looking-
just a matter of semantics. Would it have a difference in our therapeutic approach to it? Would we need to treat this calcific nodule in a different fashion than just having a little calcium in your atherosclerotic plaque? That's my question.
Yeah, so I think that that's a great question. So in a routine case, when we see a calcified nodule like that, and if the lesion is very tight, and if the remainder of the wall was pretty thin, then I would be very careful about dilating that area aggressively, because that can potentially lead to a perforation. So we have had a case like that where we had perforated an artery exactly at the site of the calcified nodule. We prefer not to do very aggressive rotablation or very aggressive balloon dilatation, depending on the lesion type. But that's usually our sense of it, and that's how we evaluate it. But in this case, I don't think that, we need to be too fancy. Given the patient has renal insufficiency, I think that we can just do primary stent here, post-dilate the stent with a 3.5 millimeter balloon and in a proximal segment, and then we'll do another OCT run if everybody
Some
agrees.
comment.
What is the etiology of ACS? Is it calcified nodule, ruptured plaque, or plaque erosion?
Yeah, so I think that in this case, the only thing that we have identified so far is the calcified nodule. We definitely do not see a plaque rupture in there. We also do not see a clear-cut erosion. So we just we'll have to assume that this was a calcified nodule that was the cause for his ACS. And also he has a lot of disease in addition to that. A very tight stenosis. The other obvious possibility is that if there was an erosion, but now given that he's been on therapy for over 3 days, that the erosion is healed and we don't see the erosion, that's possible as well, because he's been on aspirin as well as ticagrelor. He's been on heparin on top of that and had gotten streptokinase. So, he's been on a solid medical therapy for 3 days.
One last question. If one looks at the longitudinal section of your OCT, just distal to where you have labeled that calcified nodule, there is an extensive lipid-laden plaque which
Yep.
has narrowed the vessel to almost complete obliteration.
Right.
And I think this is an erosion, maybe a small erosion over there which has got recanalized, and the calcium is part of the entire longitudinal atherosclerotic process. It's within. When we see a nodule and label that as the cause, it's the nodule and nothing else. If one looks at this particular vessel in its entirety, I think the extensive atherosclerotic
So
process.
this point was actually made by Raj last evening. He said that very often you will get a mixture of the 3 lesions which you would get. You cannot semantically distinguish one from the other. I think we should carry on with the case.
Yeah.
Yep. Let's have a stent 3033.
In the meantime, Javier, would you like to, Escanet, would you like to make a comment on the OCT findings? Can we get the mic?
Thank you. No, I think it's of course very interesting. It's a case that illustrates the power of OCT to understand the substrate and how this has implications for the patient. I think this is really important. By the way, as you know, there is also a very interesting study coming from Rome, from Filippo Crea's group, that basically looked to the outcome of long-term in patients with acute coronary syndrome that have ruptured plaques or that have, like in this case, erosion or intact caps of the plaques. And actually they found that these patients have better outcomes in the long term than those that have plaque rupture. So it is very interesting, and there are several studies that are trying to concentrate in seeing if we actually, with this information, we can also think for the future whether there will be a subset of patients that require prolonged DAPT treatment based on the findings.
That's good.
That's good.
No, I think this is good.
Thank you, sir.
I would go ahead and deploy it.
So one day small.
Yeah.
Fluorosave and run it. You're happy with that?
Yeah, looks good.
Yeah. It's not impinging on the circ. We'll recheck in RV caudal.
No, we can check an AP caudal.
Yeah, AP caudal, yeah.
The left main was very short. We can check.
You are not protecting the side branch?
No, we are not. Okay.
Yeah, just go slow. Sure. Yeah.
Okay.
I think we are very good.
Yeah. We can pull back a little bit actually.
Yes, into that segment. Yes. I think we are
There
right.
we go. That's perfect.
Yeah.
Okay.
So we'll go ahead in this view.
Yep.
Yeah, inflate. So the diagonal, as you said, is not a big vessel, and in case 12, in case it goes down, we can always provisionally, we can use the strategy, bail out wire and then do it. It isn't, the angle is not very difficult for us to enter in case it's needed.
Deflate. Okay, we'll take a 3.5 non-compliant balloon.
So what was the inflation pressure?
It was at 12 atmospheres.
All right.
This is a, what variety of Zions was this?
Yeah, go back
Expedition.
to RO
Yeah.
here. The distal vessel was slightly lesser than 3, so we were very.
But we
not
felt
so
that there was some
ambitious.
spasm there from this guy having an MI and stuff. So we were a little generous with the size of the stent distally, but I think it should be okay. Uh, 12, yeah. Okay, so we won't inject any
So
dye.
I'll
Let's just check.
make sure one small semi-puff. Fluoroseal diagonal is going down, so we might have to wire it. I
Now
think
we'll
should
see.
we wire it now?
No, let's just post dilate, because even if we want to do something with the diagonal branch, it will be better if we post dilate the proximal portion of the stent and do a pot, and that's going to increase the size of the cell against the diagonal origin, so it will make it easier.
So this is 3.5 into 12 NC. Yeah.
Comments from the panel.
You have a
Dr.
stent
Sahu?
boost. Wow. Leave it, leave the.
So wire bias due to the proximal vessel is quite large. Okay.
So I will.
This is a,
choose
what
the
is an
guide.
C-track?
Yeah,
May I try?
yeah. I think we just have to beat the bias now. I am changing the wire.
Yeah,
Yeah.
I would pull back. There you go. You're in.
Now I'm getting the guide back. It was just defeating the wire bias there. Yeah.
So we don't want to go too far distally, because the distal vessel was not 3.5. So I would just want to do this with the proximal portion of the artery.
Which? Can you have a different syringe? You have a stent boost? 3.5. I think we will get back and then do it. I think. Or this is a 3.5. We don't want it. Okay. We don't want it
So
in this
distally
area.
we don't want a 3.5
Yeah.
because the reference lumen was not nearly.
So we'll go from there, I think.
So we still have a lot of stent proximally.
Yeah, I think here we can go ahead.
Yeah.
Yeah. 12.
So there was an interesting data which was presented at C3 this year by one of the colleagues in US looking at the duration of post-dilatation balloon angioplasty, and very elegantly showed that that we want to keep these balloons inflated minimum 60 seconds for post-dilatation. That made a huge difference in MLA and also post-procedural FFR values. So maybe we can do that here proximally. Okay, that's good.
Where's the stent boost? Yeah. The dot.
Perfect. Yeah.
Do it. Inflate.
So let's keep it inflated here.
What is the inflation pressure?
Inflation pressure is 12. Let's go up to 14, 16. Okay, let's keep it inflated there for 60 seconds if we can.
Would it really matter if the stent strut size is thinner, as in the current day generation stents? Would the duration of the balloon inflation still matter as much?
Yeah, so this data was 2 years old, and it was definitely not with the third generation stents such as Sierra, Onyx, or Orcedo. This data was all generated with Zions and previous generation of DES. But here in India, Sierra is not available, Alpine is not available. So And Zions really is the leading stent in the country.
NTG, Plurosave, run it, and PA cranial.
So I think this is not a bad idea.
Yeah,
Yeah.
some slow flow.
So because of the fibrofatty large amount of plaque and our dilatation, we are seeing some slow flow.
So let's take a review from the audience. How many people, if you can raise your hands, would have wired the diagonal before putting this direct stent into the LED? So in a show of hands, I think we have at least a 60%, maybe 70%, 80% people who would have wired the diagonal.
Yeah, this
No,
is
no,
the
we are talking about a prospectoscope, not a retroscope. Okay.
yeah, but we don't necessarily feel that way
No,
because
that's
we don't
fine.
think
That's
that-
fine.
Yeah.
There's more than one way to skin a cat, so
Yeah.
that's fine.
See, in the era of primary PCI, you have seen a vessel which was there before 2 minutes and now it's gone. You can easily enter that vessel, provided
Yeah.
the angle of entry is not challenging like a 90 degrees.
So we can take the non-compliant balloon out and do another OCT run. I don't think that we need to chase this diagonal branch in a patient who had an MI with an anterior wall. This diagonal branch is not very large. There is still flow in it. For
Dr. Raj, how OCT guidance will be helping us in predicting the no flow more than angio guided?
well, we knew in this particular case that there is a potential likelihood of no reflow here, given that we had seen that very large fibrofatty plaque. So when you have such a large lipid pool, this is a potential inevitability sometimes that this can happen. But the only solution to that would be to pre-treat the vessel with some type of a microvascular dilator. At least in US, we use sodium nitroprusside here. They tend to use more nicorandipil. So anything to
Raju,
help
but
along.
you may not even need an OCT to determine that. Here is a patient who's had a recent MI, he's been thrombolized, he's got a long lesion. There's all the potential, even if you do not do an intracorneal
Sure.
imaging, that this patient may have.
Sure,
Yes, yes.
sure.
Why was pre-dilatation not done, given the calcific nodule, fibrofatty tissue was there?
Yeah, that's not
There
really.
is a plaque shift to diagonal.
Yeah, then don't really need it in this case. The lesion's very soft and it's open.
Again, the same wire bias.
Yep.
So, hey, get near. Yeah,
Good. Good. Good.
we'll go there.
Perfect. Perfect. Okay.
Did you give something to
check something?
tackle the no reflow?
Yeah, we gave.
NTG, yeah.
We did not give any
We gave
nicorandipil.
nicorandil, no. We gave NTG, it improved.
Okay.
No need.
How many people would actually believe in giving nitroglycerine in a post-MI patient because of with the endothelial dysfunction? Maybe the concept we have is that nitroglycerine does not work. And if at all you have to use something, you have to use either nipride or a calcium channel blocker
You
or
tell
a
me,
nicorandil.
You tell.
What
Wait,
is
wait,
the
you tell.
ACT you would like to keep in such cases? The ACT.
Well, the luckily flow is normalized in LAD as well as in the diagonal branch. Okay, let's show the OCT run now. So in my lab, this would be our final run if OCT shows that we don't need to do anything further with the stents, but we need to evaluate that. Okay. So distal to the most distal stent, is there any edge dissection? That's the number one thing we want to see. Keep going, no edge dissection, okay, good. So apposition looks good so far. Okay. Reasonable expansion, keep going. I have not seen any malapposition yet. Now there are some newer software features that could make this process a little bit faster, and we can show you that stent rendering. Now I use it sometimes, I don't use it other time, depending on the case. Okay, so there is no proximal malapposition, there is no edge dissection. The stent looks all white. Any red dots? A little bit distally.
Can you enlarge that stent rendering? We are not able to see it.
Can you show only the
Can
OCT?
you just show the OCT image rather than the angiographic image?
Yeah, take off the angiogram, show the OCT large on the screen. If that's possible to do.
Only OCT? Yes.
Yeah, that's better.
Yeah.
So I would say that the distal portion of the stent could use a post-dilatation with a 3O non-compliant balloon. Although it's not bad. There is definitely no edge dissection, no malapposition. The distal portion of the stent could I could be convinced to post-dilate a little bit more with a 3O non-compliant balloon, which we have not done.
What is the size of the distal vessel?
Distal vessel was 2.68 on a reference.
Even now?
EEL to EEL.
Now you check that. I think once you had a slow flow, I think maybe it's needed because we are already judiciously.
Yeah, I think this is very acceptable.
Yeah.
This is very acceptable. There's no question.
And the diagonal flow is good. It's back to what it was. Maybe some spasm and the NTG really helped.
And the calcific nodule has been suitably
yes, even
subjugated.
in that area. Yes, I think the expansion was good. You see, not just it was just a pure fibrous plaque, a lot of lipid underneath. That's the reason we thought in the setting of ACS, STEMI, we could get away with the primary stenting directly without doing any pre-dilatation.
If you look at the automated lumen profile, you could see that the distal end of the stent, the second half of the stent appears to be under expanded.
Yeah.
In the lumen profile.
So that's why he was wanting to do a 3O NC balloon.
Correct.
Yeah. Can you show that distal
Yeah,
end?
it's a 4.7. So I think I prefer a 5 or greater.
Yeah.
Now because he has renal failure, so I won't do another OCT, but I think that we would like a 3O by 12 or 15 NC balloon.
You can take this off.
Yeah. And we'll post-dilate it once, the distal portion of the stent, and be finished with it.
Yeah, NC? 312.
So we can come back to the angio as well?
Yeah. Now show the angio thing.
Now save the image. Save. Now once you save this image, now realign it and see if we have to land in proximal LAD.
So Raj, just a hypothetical question. Suppose the creatinine was, or the EGFR was 15, and you still wanted to do an OCT guided, would you use any other non-contrast substitutes for clearing the blood?
We do use dextran at times, however, we also have seen some reactions from dextran, so we're not so thrilled in using that much dextran in these cases, but you could do that. We've also tried using some diluted contrast. We sometimes don't get very good image, but it can be reasonably good enough to make a decision such as this one, that we need to post-dilate the stent
12,
or something.
14,
16.
16.
Dextran is not that renal safe, no? So.
Yeah. What do you do? Do you have any other ideas?
Pratap says he won't do an OCT.
Huh. So that's always an option.
And maybe you could go and use an IVUS.
Yeah.
Yeah. One more.
That's a very reasonable thought.
Yeah.
12. The diagonal is there. Okay. We're done that part anyway with the 3-5. Who can come out?
Okay. So one quick run.
We'll give some NTG and come out.
See, we're still trying to prove that the FFR, IFR, OCT, IRIS change outcomes. But one thing which all the stent companies have actually universally used is using a stent boost. It is so simple, but I think it really helps us in our, and we don't have a randomized controlled trial to demonstrate the benefit, but we all in everyday practice really get benefited by using a stent boost.
Okay, picture.
Follow?
Beautiful.
Oh, excellent.
Good result.
So,
Good result.
Okay, great.
good job.
So nice TIMI3 flow. The blush grade is also appears to be at least 3, between 2.5 and 3, I would say. The diagonal flow is good.
And yes, the distal part of the stent is also looking good now. So,
Looking better.
yeah.
Yeah.
The diagonal is flowing.
Diagonal's flowing well. All right, great job.
Yeah.
Thank you.
Thanks.
Okay, thank you very much, everybody.
Thank you all.
Give them a big hand.